So I am delighted that you are here this evening and so pleased to welcome Rob Gurnee, who is the Executive Director at LCS, also known as Lutheran Community Services. And I guess, Rob, you've been there for 8 years. Was it 2017? Um, and so he's had a major role to play in the LCS strategic vision and programming, financial management, the organizational culture, and fundraising initiatives. And in his spare time, I'm not sure what spare time he has. But in any case, one of the really significant programs that LCS has undertaken under Rob's guidance is a program called Food is Medicine through something called the Delaware Food Pharmacy, which is spelled with an F, that addresses health equity and healthy food access issues. And Rob will share some information about that with us this evening. He has a broad, both profit and nonprofit leadership background, and has served in a number of faith-based organizations, and also very involved in Wilmington's West Center City neighborhood. And so for educational background, he is a fellow political science major. I always like to introduce other political science majors. And also has a law degree from Emory University School of Law. So a very significant background, wonderful accomplishments with LCS. And we are so glad you're here tonight, Rob, as we are aware at some level about the significant issues with hunger and food insecurity in our country. But quite frankly, most of us don't experience that firsthand. And so there is an intellectual understanding about the issue, a certain level of awareness of decisions being made at the federal, state, and community level. But we look forward to your helping us to really comprehend the severity of the issue, what is needed, and how we might be involved as individuals or as communities of faith to help make a difference in ensuring that our neighbors have access to healthy food. So let me turn it over to Rob.
Well, thanks, Sue. Thanks, Sue, and good evening to everyone. I really respect the spirit and the commitment of this group. I've seen all the topics or many of the topics that you guys delve into over the years, and it's just a real tribute to your interest in the important issues in our community. Sue and Bob have been friends of LCS for many, many years, and so yeah, I'm delighted to be here today. And this is a small group, and so I would think as I talk, I have a PowerPoint presentation, but as I talk, just if you have any questions along the way, just unmute or raise your hand, and we'll just go down that path as we talk about things. And so, Sue, if you would let me share, if you
I
haven't
think
already,
I think you can.
yes, I can, and I will do that. And super. So Sue had put a title on this, which is a good title, Confronting the Intensifying Hunger Crisis. And as I was thinking about it, I would just maybe expand it a little bit to say that we are confronting an intensifying hunger, nutrition, and diet-related health crisis in this country, and particularly in vulnerable communities. And so um, those three areas, hunger, nutrition, and health-related matters will sort of be the arc of my presentation today. And just let me take 2 minutes and tell you a little bit about our organization. As Sue mentioned, LCS stands for Lutheran Community Services. And our mission here really focuses on providing essential needs for people. And we really, it's baked into our DNA to provide those services with dignity and respect and in a caring and compassionate way. Sometimes I talk with our staff about one of our most important things that we can do is to have a ministry of presence for people as they come to us facing trauma of different sorts. And most times we can help them with something, but if we can't, at least that we are there in a way that lets them talk about the issues that are going on and to journey with them a little bit and to be present with them. And I think that's really important. And it certainly distinguishes us, let's say, from state service centers who provide essential needs. And then our vision is to, you know, it, one day we wake up, that should be the catalyst for or the way to think about any vision is if you've done everything well, you walk in one day, what would it look like? And it would be people moving from emergency to empowerment. And so over the years, we've taken on a lot of evidence-based programs where we can measure outcomes and sort of operate on a both end basis, right? Doing ministry, doing charitable work, as well as some evidence-based programs where we can measure impact. Um, and this is just a thumbnail, and you've probably touched on most of these topics in your other sessions along the way. You know, the clients that we work with really are on a roller coaster of food, financial, and health insecurity. Um, Most of them, 60% is probably a low number, live paycheck to paycheck. Um, Folks come to us for rental assistance or utility assistance, and they're often paying 50, 60, 70% of their income for their rent and for their utilities. And so, of course, I wouldn't even call it an emergency, just any derivation from that budget formula will set them into a tailspin and put them right on the brink of homelessness. 1 in 5 children in Delaware in 2025 are food insecure in some way. 1 in 8 adults. Um, Tremendous inequities in our healthcare system and access to healthcare, which of course exacerbates chronic disease and limits the well-being and the potential of many vulnerable populations. Um, our populations are targeted for cigarette smoking, which is both a health detriment and a financial burden. Um, and then we saw during COVID, all of this sort of rear its ugly head. They were disproportionately impacted by COVID. Inflation is ravaged. And so it's just it's just a perfect storm or an imperfect storm, as it were, of obstacles that our clients and our community neighbors face. And so the way that LCS has gone about trying to address some of these, and we've been doing it for 66 years, not all exactly in this space, but we started building senior high rises, low income senior high rises. We built Luther Towers and Luther Towers 2 and a number of similar sites down in Dover. I think we built about 6 of them over the years, eventually spun them off to an operating company. But we primarily focus in food, and that's what I'll talk about tonight. The housing stability portion, which I just mentioned in terms of rental assistance and utility assistance. Um, and then tobacco cessation. We've been a partner with the Delaware Quitline for a couple of decades. 15% of Delawareans still smoke, and 20% of high school students have engaged in vaping in the last 6 months. So it's still an area that needs to be addressed. Um, so turning the focus to food again, which is what we're our topic for tonight. I want to just chat with you a little bit and tell you how LCS has met the needs that we see and how we've developed partnerships, added value, and built infrastructure in order to provide sort of a holistic approach to the problem. And kind of a spectrum here along in the food space, right? On the left-hand side is your basic emergency food. It's your pantry. It's designed to fight hunger. It's where the largest number of people come for assistance. It's what the food bank does. It's your traditional sort of pantry. And then if you go along the spectrum a little bit, there's a more of a focus, an intentional focus on nutrition, and we've been trying to blur the line between food insecurity and nutrition insecurity. And so we purchase a lot of healthy foods. I'm admitting someone here, Sue, into the meeting. Um, we provide a lot of healthy foods for folks, and um, we don't have specific outcomes in this area except for survey outcomes and anecdotal outcomes. We know that as a result, people are intaking more fruits and vegetables. We can survey them and find that they're trying new foods, that their eating habits are changing. And then on the far right hand of this spectrum is the program or the space that Sue mentioned, and that is food as medicine, where we have a healthcare partner involved, and that would be Christiana Care, and where we are utilizing food to prevent and to manage and to treat chronic diseases. And it's a very comprehensive and structured intervention, and I'll talk about it in a little bit. But so LCS, you know, is one of the few players in the state that is engaged in all three of these areas, because there's need in all of these areas. Um, so if I were to talk first about food insecurity on the left-hand side, we have a number of different ways that we provide folks food in that area. We have three pantries that are open on a daily basis during the week. Some are open 5 days a week, some are open a couple of days a week. We have a number of monthly distributions and then some senior high rises that we service. And so this year we'll end up having about 27,000 household visits, serving some 60,000 people with food, which is incredible. And that's a pretty big increase over the last couple of years, about a 37, almost 40% increase over the last couple of years. And we're seeing increases, other pantries, the food bank, look at national statistics. It's going up sort of everywhere. And I think that where the crisis comes in is not only the fact that, 1 in 5 children are food insecure and that we're serving all of these people, but it's getting harder, right? You've probably heard in the news about different requirements for what they call SNAP, right? Which is Supplementary Nutrition Assistance Program, or food stamps. they've changed the rules for SNAP to make it harder for people to access it. And so before there used to be, they now have work requirements. They call it able-bodied adults without dependents, and they measure that in a different way than they used to. So they used to exclude veterans from that definition. They used to exclude people who are experiencing homelessness from that definition, young adults who are exiting foster care. Um, the age requirements now, you have to work until you're 64 years old, and a dependent now, it used to be anyone under 14, anyone under 18 was considered a dependent, and now it's 14. And so you're seeing older people um, who are in, difficult situations, having to prove their eligibility for SNAP, and they have to do it, periodically. And many of these folks work multiple jobs. Many of them are in the gig economy, getting paid cash. They can't just go to their HR department and get a copy of their pay stub, or it just becomes more and more difficult for them to maintain their eligibility. And therefore, chances are the number of people who are served by SNAP will decrease, increasing food insecurity and nutrition insecurity and health insecurity, and put pressure on organizations like ourselves to try and fill that need. Of course, Medicaid now also has different work requirements. You're seeing ACA health premiums go up. And so it is a crisis. It has been, and it's getting worse, quite frankly. Um, I don't know if we want to just reflect on that for a minute, or if anyone has any questions about sort of that state that we are in. Not, I'll just tell you where we get our food to feed these folks. So,
Rob, it
yeah.
strikes me as you're talking about the changes in the SNAP requirements. I've heard the bromide. There's fraud in the system. People
Mm.
are getting benefits that they don't deserve. We need to be sure that people are pulling their weight, paying their own fair share. But it strikes me that the kinds of changes you're talking in the SNAP requirements are being done without regard for the realities on the ground, and in fact, are hugely punitive. I mean, veterans now have to go through this process. If you have children who are 15 to 18 that you're seeking to feed, I know there are disabled people, people who can't work as they get older, and it just seems here, as well as in other aspects of program changes, that the casual cruelty is sort of the point. Um, and I'd never really given thought to what you spoke about, which is, I hear it said, well, people are working multiple jobs and it's really hard to get someplace, but the idea of how do you prove you have a job if you're being paid cash, if you don't have a pay stub or I hadn't thought about that part of it. How do you prove that? And how often do you have to prove it? I mean, it just seems overwhelmingly punitive.
Yeah, I think many analysts have said that it is not likely at all to actually increase the amount of work that people do. it's just likely to decrease the number of people who are able to receive benefits because of the administrative burden and just the hassle, quite frankly, in a busy life to comply. And so there is a casual cruelty to it. I think that's a good way to describe it. And we see folks every day, and you obviously, as I said at the very outset, we're very non-judgmental. We're accepting people and welcoming people, and undoubtedly there are some percentage of people and who possibly are gaming the system, but it's a very small percentage. And to sort of lay down draconian and imprecise set of rules to try and address this mythical sort of population, I think ends up just hurting more folks. I mean, the analogy to me would be around like election fraud, right? You come with these draconian measures to combat quote unquote election fraud, which has been shown to be very, very minute. And so you sort of throw the baby out with the bathwater. So it is tough, and it puts the burden on organizations like us. And um, one statistic that came out during the recent government shutdown is that I think it's for every 10 meals that someone receives, only one of them is provided through organizations like us. The rest
Mhm.
come through federal assistance programs, be it WIC or SNAP or other benefits. And so the thought that nonprofits are going to fill the void is foolish. Um, so just from an operations standpoint, we get a fair amount of our food from this program from the food bank. Um, they work hard. They've got a lot of hunger relief partners. Um, we buy our food from them. It's at a subsidized rate, but we do purchase it from them. But then, since we are focused on this nutrition piece, we also supplement what we receive from them, what we buy from them, with a lot of local farm product, fruits and vegetables, and lean protein and dairy. And then we get a small amount from the USDA, and we purchase some food. So that's just sort of a quick flyover for that space on the left hand of the spectrum: emergency food, food insecurity, hunger. And as we move towards the middle one, nutrition security, here's a couple of programs that we do in that area. We have one that we call Lettuce. It's healthy food hubs for schools. And we partnered with University of Delaware Cooperative Extension and Children's and Families First. Christiana Care helps us with this as well. And part of the program was underwritten by Christ Church. And so we provide healthy food in three and now four Wilmington schools: um, Stubbs, Baynard, Harlan, and Warner, and trying to introduce nutrition education, trying to create conversation about how folks grew up around their table, what they ate, what mealtime sort of routines they had, what they're doing with their family, and just kind of introducing the concept of healthy food and how it impacts their well-being. And it's been reasonably successful. It's it's as I'll talk about a little bit later in the food is medicine. It's sort of one thing to provide healthy food. It's another thing to really be with them and create some behavior change that allows them folks to utilize it in the best way possible. Another nutrition security program that we call Nourish, and it's with a small nonprofit called the Healing Tree. Um, started by a former Presbyterian pastor and chaplain at Nemours. And we provide here medically tailored food for children and their families who are suffering from sickle cell disease. And here they use church volunteers as food coaches to show folks how to utilize the food, share recipes. And again, their ability to provide outcomes is a little bit higher than the school. They can map reduced hospitalizations as a result of this program, increased doctor appointment compliance, increased knowledge of food, increased cooking skills. It's a small program, but it's one where it's really well run. We love our partner in this, and it's just another area where we can sort of add value beyond just a traditional pantry. Um, and then as we go to that far right end of the spectrum, the food is medicine. Um, this is a really a burgeoning area, both in the state and nationally. I was at a conference about 3 weeks ago in Washington, and Governor Matt Meyer gave the keynote address. There is an active food as medicine committee in Delaware, and I'll mention that in just a moment. But it really recognizes the critical link between nutrition and health, and tries to make food a part of someone's health plan, part of their treatment plan. And it includes provisions of nutritionally tailored meals, groceries, and produce. And if you talk about how we talked a little bit about hunger, but if we look at the impact of poor diet on our society, I mean, poor diet is a leading factor for mortality in the U.S., contributes to over 600,000 deaths annually. I think it represents something like 85% of all healthcare spending is from diet-related chronic disease treatment, over $1 trillion. 61% of the deaths in Delaware related to chronic disease. Our obesity rate, our overweight rate, our diabetes rate is just it's it's you know objectively uh, a crisis, and it's only exacerbated in vulnerable communities where the access to healthy food, the money to purchase healthy food, um, and maybe generations of experiencing that, such that even if they are able to receive healthy food, sort of understanding exactly what to do with it and how to utilize those foods might be compromised. And so we see it in our lives. It's forget about considering this in the realm of a nonprofit serving vulnerable populations. I mean, you can't go a day without watching TV and looking at weight loss drugs and or processed food commercials, or we're just saturated with this in our culture, and it's it's has reached a crisis state. So um, I'm sure you have observations of that in your own lives, right? We've all dieted before, but it's one thing to diet, right? To maybe lose weight, but it's another thing to be on a health regimen. And often we get scared into that based on maybe a diagnosis or a doctor telling us what to do it. But to be able to do that as a lifestyle and to be able to really bend the curve on this is a challenge. And there is a food as medicine pyramid, right? At the top of it are medically tailored meals. And these are prepared meals. This is not Meals on Wheels or anything like that. These are medically tailored meals. Very expensive. It's typically for folks who maybe are coming out of the hospital or don't have the wherewithal to prepare food for themselves. But it has shown a tremendous impact, obviously, on health outcomes. And then the space that we're in, right below that, is medically tailored groceries. And I'll talk about the food pharmacy in a little more detail in a minute. Um, and there's produce prescription programs. Their fourth level, they call nutrition security programs, but I don't really think it's nutrition security. I think it's mostly food security programs. And then just at the very bottom, food policies and programs. So this is kind of the lay of the land. This is some of the language that we use. And the higher up on the pyramid is where we go from prevention into treatment. And then on the other axis, we're going to, we're getting more involved in nutrition counseling and education. Um, and so our program is the Delaware Food Pharmacy, and we partner with Christiana Care. And we have two pathways. One is food secure, insecure patients at Christiana with chronic conditions, diabetes, congestive heart failure. And we deliver medically tailored groceries to their homes. And these are groceries that comport with the DASH diet. And it's we provide 10 meals a week for 10 meals per week for their patient and each family member. Folks are in the program for 6 months. We've adapted it for Spanish speaking patients. And then sort of the secret sauce to this program is that Christiana uses community healthcare workers who meet with these patients on a weekly basis and show them how to utilize the food. They cook with them, go through goal setting, um, and really sort of try and drive that behavioral change that we see. We expanded it last year to their women's health area, and it's for women with high risk pregnancies. So try and prevent, try and have women carry their babies full term, reduce growth restrictions, preeclampsia, gestational diabetes. Um, they're in this program for more like 8 months. We provide a Mediterranean diet here, and in this program or this expansion, the community health workers play an even bigger role because they're the moms are 7 and 8 months pregnant and have mobility issues and maybe need help getting to their doctor's appointments and just don't have the energy or the time to want to cook meals and fully be engaged. And so, our healthcare workers are just community health workers are just angels trying to get them to the finish line in the best way possible. And as you'll see in a minute, it works. Here, we we see a reverse in where we get our food from. We get a good portion of our food from local farmers, and then we purchase a good deal of our food because we have to provide a consistent menu. We can't, just provide what we have when we have it, which tends to be the case with the food that we get from the food bank because that's the situation that they're faced since they're receiving a lot of food from donations. And so it's an expensive program, and we are providing them with a menu that includes choices of fruits and vegetables and grains, lean proteins, dairy, um, nuts, snacks, beverages. We're also providing them, we give them a starter kit when we first meet with them. And if they need cutting boards and knives and mixing bowls and all of that, we'll do a kitchen survey and provide all of that to them. We'll give them some oils and some spices to begin with, and then periodically replenish those. And so it's a very comprehensive program. And here's our farmers that we work with. We're always looking for more farmers. This is sort of the virtuous cycle where we're able to purchase food from local farmers and sort of sustain their operations and then have that food go in this program with help so many people. And so, we're adding value as a result of this. We are seeing specific outcomes in weight, in BMI, in A1C levels, reduced anxiety and depression, obviously improvement in dietary intake. The moms are reporting, pregnancies where they carry them to term for the most part, reduced postpartum depression. They're breastfeeding in many cases. They compare and contrast their pregnancies under this program with prior pregnancies, and it's just been night and day. And this year in this program, we will have provided enough food, healthy food, DASH diet and Mediterranean diet compliant food that allows people to create 100,000 meals. Um, and sort of the other way that we're adding value, this was sort of a infographic that we come up with as we were envisioning our work. And you know, looking from the bottom up, we look at ourselves as a food aggregator from a number of different sources. Most pantries just aggregate food or just receive food from the food bank, and that's what they do. They turn around and hand it out. But we're receiving food from the food bank, from the USDA. We receive a lot of donated food. We purchase a lot of food from retailers and wholesalers. And of course, we purchase a lot from Delaware farmers. What's not on here, and I need to update it, is, we do some amount of food rescue as well from local retailers who um, have food that they would otherwise dispose of, and they give it to us. But we aggregate this food and then we send it out to our existing pantries and our school-based pantries and the Delaware Food Pharmacy, our community partners like the Sickle Cell Program, and then always looking for other nonprofits who are engaged in, intensive work with their clients where we can introduce healthy food into the equation and provide another way that they can connect with their clients and improve their well-being. Um, Another way that we're adding value is we upgraded the space in these school pantries. You can see this one on the left-hand side. This was at Stubbs Early Learning Center. It was basically a space in the basement, and we went in and we cleaned it out, and we painted it, and we put in floors and tables and refrigeration. Um, all of our pantries are connected with a cloud-based system. So we're able to measure all our activities. We're able to look at the demographics of who we're serving, generate reports, and just really operate it on a more professional level than sort of your average mom and pop pantry. And then this past year, we broke ground last year, and in March of this year, we moved into an expansion. This is our building on the left, and on the right is and not a Photoshop, but the actual picture of our new 3,500 square foot warehouse that we're able to utilize to run this program. And then I'll just lastly say that another way that we're trying to build infrastructure is with our leadership on the state's Food is Medicine Committee, um, which is designed to improve health equity, ultimately to reduce health cost savings, and to provide, some economic growth for our local farmers. The goal really of this committee, or the first goal anyway, is to continue to collect the data on the health outcomes and to be able to show to private payers, health insurance companies, and to Medicare that food really is medicine. If it's reducing hospitalization, if it's reducing A1C levels, if it's reducing blood pressure, and to have those entities pay for the food. This happens in other states. And we have around the table with this committee, Delaware Medicaid and Medicare. We have Highmark. We have the lieutenant governors is leading the charge on this. LCS is at the table along with the food bank. Um, so, you know, if I had to look forward, I would say that in about the next year or year and a half, you would see the next level of scaling food as medicine in Delaware, right? We're doing this on a relatively small scale, but I would say in a year and a half, I would envision a very structured network of providers that are providing the various parts along that food as medicine pyramid, medically tailored meals, groceries, and produce prescription, where the food is being paid for by Medicare or insurance companies, and we are actively measuring the impact. Our women's health program in the Delaware Food Pharmacy is currently in a clinical trial, right, where the University of Delaware is measuring the results with a control group, and we're utilizing some of that data to drive our goals here for a reimbursement model. Um, Lots of ways for folks to get involved with LCS. I won't make this a commercial, but we have a number of events, one of which is near and dear to the heart of Sue and Bob every year, which is the golf tournament. We always need volunteers for our food pantries and at our events. We receive lots of donations in terms of hygiene items, which is another thing that we do in addition to food because it's not covered by SNAP benefits. It's very expensive. And if we can provide it, it frees up money for folks to spend on other things. And of course, donations are always welcome. So with that, I think I've talked for 45 minutes. So I hope that you have some questions or some observations or some suggestions. I'd love to hear them. And yeah.
Rob, if you would stop screen sharing, then we'll be able to see people
I will do that.
a
Good
little
idea.
bigger.
Thanks.
Thank you for that, Rob. And you're right. Our title for this program was about hunger, and of course, it has to do with food, but it is obviously so much more than just basic hunger needs, but rather a range of opportunities for transforming people's lives and health and well-being. So thank you for sharing all of that, much of which I think we really didn't have any idea. I will make a point to the Westminster members that when the food pharmacy pilot started, that was something that Westminster's Urban Mission Committee made a contribution because it sounded intriguing and it was not our traditional food pantry approach. And while our involvement was small, it was with an appreciation for what might happen. And so it's grown well beyond what our expectations were, and it's exciting to think that a broader reimbursement model might make that program much more widely available. I'm assuming that it is funding predominantly that is the limiting factor on opening this up to a wider community.
Yeah, it's both funding and, I said the first goal of this committee was this reimbursement model. Sort of the next layer is to build capacity to deliver this program, and particularly across the state. Um, when I was at this conference in Washington, as I remarked at Westminster recently, the woman who runs the program in Massachusetts said that, gosh, that reimbursement model ended up being the easy part. The next hardest part, or the hardest part, was bringing together a coherent network and a coherent standard for all the organizations to work around. And so I think that there does need to be some more development on the ability to deliver on this. I know the food bank has heretofore they've had a culinary medicine, or excuse me, a culinary program that provides job skills. But if you think about it in this realm, it could be a culinary medicine program, which could still provide job skills, but also provide now medically tailored meals. Um, and I think a number of places would be able to handle the produce prescription part of the pyramid, but I think building out our network is going to be an important role. That's the committee that I'm on, is the implementation and capacity building committee. So,
Okay, thank you. Roger, you had your hand up or have your hand up?
A little bit more on the food as medicine. It's a very intriguing idea to have the benefiters, which are, lower medical costs and other benefits. And you said it looks like you could bring them into being a payer for part of the program. How would that work on volunteer basis, twisting arms, legislation? How would that come about? Because, you know, everybody's fighting over the dollars right now.
right. Yeah, it's all of the above. So if we were to get a Medicare 1115 Medicare waiver, that would say that the federal government has told Delaware that you are allowed to use a certain portion of your Medicare funding for this alternative path. And then the state of Delaware would determine what proportion of that lump Medicare payment could be used towards food as medicine. Um, there's something called payment in lieu of services, where that would be on a voluntary basis, where certain providers who use Medicaid and Medicare could decide that instead of accessing services through that route, they would want to utilize this service. There could also be an administrative action by the governor who just set aside a certain amount of fund of money for this.
Mhm.
And there's already been a little bit of that. This farm program that I talked about, that we used to receive funding from the federal government for that. And that was terminated in July. But the state picked that up because they saw not only the importance of food as medicine, but we were just starting to build some stable supply chains and new markets for small farmers in Delaware. And so they saw the benefit of that. And so there was an example of the state coming in just sort of unilaterally and doing it. So it's kind of an all the above approach. And I think there's, a dozen or so states that are utilizing different mechanisms. We just had a law and policy group from Harvard Law School speak to the committee, and they basically gave us a primer on how each state has gone about it. And it's a multifaceted approach in each, because you don't want to put sort of all your eggs in one basket. North Carolina had an approach that was state driven, and the state legislature sort of shifted and that program went by the boards. So yeah, I think we're being really strategic about it. We have some really good people around the table. It's a great
Well,
question.
it makes it very important to have the data to support
Yes.
the conclusions. And it seems like a natural for somebody in the University of Delaware Ag Department to, do a PhD thesis on it or a master's thesis, or, taking all that data and massaging it, putting AI on it. And, it's a
Yeah.
a
Yeah,
great
there's some really good folks. There's a professor at University of Delaware, Allison Carpin, who's been doing some really good work on it. she's published a lot of papers in the area. And Christiana Care has an embedded research department as well. So yeah, that's a critical piece, absolutely. And so our program is, I'd say, the furthest advanced in terms of collecting that data in the state of Delaware, but we know that's another area of capacity building that we need to do statewide.
Thank you.
Other questions or comments? I will make mention of the healing tree because Pat Weichert is the Presbyterian pastor who is the former Nemours chaplain who began that program working with families dealing with sickle cell disease. And so Westminster has had an association with that program from the beginning. One of the notable things that program is doing now is applying for $25,000 in presbytery level funding for a program. And Westminster is the sponsoring church for that Ignite funds request. We were also asked if there might not be members of the congregation who would be willing to serve as food coaches for the families who, in many instances, are needing to learn how to use food in a way that helps the patient, or at least prevents the situation from being aggravated by whatever food choices are made. And we actually had a volunteer who was willing to do that recruiting, but then she ended up going to seminary. And for some reason, that took a lot of her time. But that is something that the Urban Mission Committee has looked at, and we have added the Healing Tree to one of the partnerships that we will be supporting in the coming year. And so
That's
if there's a
great.
way that we
Yeah.
can get engaged and involved in, peripheral programs or related programs, that would be wonderful.
And as I'm sure you know, because I gather you have a cause that you're involved in or been involved in perhaps as a volunteer, but volunteering is a community. Our volunteers love to come to our location. They love being with one another. They love serving the community, and they've become friends outside of volunteering. The social bonds and the service that they provide are just very important parts of their lives. And so I encourage you, whether it's us or the Healing Tree or any of the other organizations that you're all familiar with, nonprofits count on volunteers to be the lifeblood of our organization. So
Roger.
combining that with sort of the intimate knowledge that you have is a great combination.
Well, and quite frankly, I had a personal interest in the Healing Tree because when I was the administrator at Westminster, I met Joan Truitt, who was a sexton at Westminster at the time. She was actually a contractor, has since become an employee. So she's been at Westminster for 30-some years as a sexton. But her daughter, Shireen, suffered from sickle cell disease at a point when it was much more difficult to manage. Lack of access to healthcare, Medicaid complications meant that Shireen couldn't get the intervention that prevented the crises from happening, that resulted in extended hospitalizations. And watching Joan try to navigate the access to healthcare, the reimbursement, the medication, the time off was excruciating. And she was doing everything that she could. And today, Shireen is a registered nurse. She is married and has a child. And it's been a wonderful outcome. It would have been lovely if she hadn't had to go through all of those difficulties to get there. And so what can we do to keep future Shireens from having to have that experience and her mom in navigating the system, so that life doesn't create that additional set of obstacles that make basically poverty so difficult. So,
Yeah,
Roger,
every time I do one of these presentations, I kind of, it tends to be a little clinical. Here's some numbers and here's some programs and all that, but the stories and the human impact is what makes us do the work. And if you get a chance, go on our website. We've got a number of videos from people who've benefited from our programs. There's one young lady in the food pharmacy program who gives a testimonial, and it's still just it'll bring tears to your eyes. And but that's a great connection that you had there, Sue, to the Healing Tree. I'm so glad that Westminster's supporting Pat. And of course, they do other things beside food. They provide transportation to families and mentoring and a number of other services. And it's
yeah,
important work.
Westminster made the space available for the mentoring program to take
Ah,
place. So the
that's
mentoring does
fantastic.
occur at Westminster, and there's probably a need for more mentors. So that's yet
Yeah,
another volunteer opportunity. Yeah.
yeah.
Roger.
Now, more of a comment um, that in our current food chain supply system, we lose a huge amount of food. And it's not 10%, it's not 20%. It's more than 30 and less than 50 probably of the food is wasted. And I would just encourage that if you are doing direct from farmers, that has got to be probably the most efficient way that we can avoid that waste. And given food from anywhere else or food direct from farmers, that's I think I'd strongly support that as least wasteful of all of those routes of
Yeah.
getting food.
Yeah, and I tell you, it's been a boon to them, and it's been extremely educational for our clients, our volunteers, and our staff to, just the size of what we get and to understand the growing seasons a little bit more precisely. It's that relationship is been fantastic, and you're right, the carbon footprint as a result of that, and is better than importing fruit from South American countries and what have you, California. So
Yeah.
yeah, no, it's a big part of our program, and that's actually baked into the state's Food is Medicine program, is to
Great.
prioritize utilizing local farmers. So good point again. Yep.
Great.
Well, thank you again for being here this evening, Rob. It's interesting. This evening, our audience is all Westminster people. Very
Ah,
often, there are a wide range of people who
mhm.
joined us for all sorts of reasons. So, if you're watching this video and you are not part of Westminster, I just want to make a comment that says that as a church, we are really grateful for our partnership with LCS. And as a church, we've always looked for partnerships to be more than writing checks, more than providing funds, but to be engaged, to be involved, to be volunteering, to make in-kind contributions, to engage the congregation. And so we will be looking for more ways of sharing information about volunteer opportunities, the ways that people can get involved, because I really do believe that for most of us, our money follows our feet. The people we know, the stories we experience, the relationships that we build, those connections speak powerfully to where our priorities are and the many ways in which we can help. So thank you very much for being here. Thank you for your leadership of this organization. I expect it won't continue forever, though I gather there's a little question mark associated.
Well, I am on the retirement path, and we'll see how that goes.
In any case, thank you for your leadership, Rob, and thank you for being here tonight. And thank you to all of you for being here. We will not meet again until after I'm sorry, that's not right. I beg your pardon. We will have one more Thursday evening next week. It is with the Gifford Center that deals with community violence prevention. And we'll talk explicitly about the relationship between the national and the Delaware activities and how progress is being made and where progress is needed. So we look forward to having you all join us next week. And then we will be off for 2 weeks until the 8th of January, figuring that Christmas and New Year's are probably not prime Zoom program opportunity slots on people's calendars, but we will resume again and are looking forward to sharing this time with you throughout 2026. So hope to see you next week. Thank you again.
Thank you all. Have a good evening.